Good afternoon, everyone, and welcome to the BWell Texas Recovery Science Echo. Thank you all for joining us today. My name is Cheryle Pacapelli, and I will be facilitating today's session. Before we get started, please note that we are recording these sessions for later distribution. Please note that anything listed in the chat does not appear in the recording. These sessions are enabled for live closed captioning. If you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. You may need to click on three dots or more menu at the bottom right of your Zoom screen to find this. If you're having trouble, please chat Echo IT. To help us with attendance, please enter your name, affiliation, email into the chat. To access the chat feature, click on the speech bubble icon on the navigation bar at the bottom of your window. To all the BWell Texas providers, please make sure that you identify yourselves during this session by entering your information into the chat, or if you're joining via phone, please email your phone number and name to bwelltx@utisca.edu. We encourage everyone to join by video for the discussion portion in the latter half of the session. That said, regardless of how you've shown up today, we are just happy you're here to learn alongside us. Please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is on the bottom left of your Zoom controls, or if you're on the phone, just press *6. You can also use the emotions menu in the bottom right of your Zoom screen to raise your hand and indicate you have a comment to share. And finally, please note that no protected health information is allowed in either the chat or our discussions. Towards the end of the session, our wonderful Echo ID support Karen will be sending out a link to an evaluation survey. Please fill it out for a few reasons. It gives us your feedback on how to refine and shape these sessions to address your priorities, and also allows you to access free continuing education credits. And all participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Our didactic today is on the history and role of peer recovery support services, PRSS, in the United States, and will be presented by Cheryle Pacapelli. This will be followed by a case presented by Elisa Sage. We'll start with introductions, followed by didactics, announcements, case presentation, and open discussion. Thank you all again for joining us today. These sessions are what we make of them, and we encourage you all to share your perspectives and insights in today's conversation. And with that, we will begin with some introductions. Cheryle.
Hi, I'm Cheryle Pacapelli, Harbor Care Project Director in New Hampshire and part of the Hub team.
Thank you so much for joining us today. Emily?
Hi, I'm Emily Hennessy. I'm Associate Director of Biostatistics at the Recovery Research Institute at Massachusetts General Hospital, and also a member of the Hub team.
Thank you so much for joining us. Sierra?
Hi, I'm Sierra Castillo de Martel. I'm a postdoctoral fellow at the Lighthouse Institute with Chestnut Health Systems, and I'm also a Hub team member.
Thank you so much for joining us. Robert?
Morning and afternoon, everyone. Robert Ashford, one of the Hub members for the Recovery Science Echo, and also one of the PIs on the Peer Recovery Innovation Network, one of the R24s that's funding supports this Echo. Good to be here.
Thank you so much for joining us today. Daniela?
Hi everyone, it's Daniela here. I'm the project manager for the Peer Recovery Innovation Network. And with me today is also Kirsten. Hi, I'm Kirsten. I just started as the project coordinator for PRIN. I'm excited to be here.
Thank you so much for joining us. Andrea Hebler?
Hello, everyone. My name is Andrea Hebler, and I'm one of the program coordinators at CSTAT. Welcome, everybody.
Thank you. And Jasmine Vidal?
Hello, everyone. My name is Jasmine Vidal. I'm a CSTAT program coordinator. Thank you for joining today.
Thank you all. And with that, we will get started with our didactics. Karen, if you could please share the slides, and Cheryl, you can take it away whenever you're ready.
Okay, great. Thanks everybody for joining today. It's really an honor and a privilege for me to be presenting on this, exploring the history and role of peer recovery support services. I am a person in long-term recovery since June 1989, and I'm a certified recovery support worker here in New Hampshire. So I got involved in peer recovery support in really the beginning of the movement around 2001 with owning recovery houses. So at that time, people told me it would take 25 years for this, what we're doing here today, to happen. And here we are. They were right. And now we're getting data. And so I'm really honored to be able to talk to you today about the history and role of how peer recovery supports came to be here. So next slide, whoever is doing that for me. Yep. So here's our disclosures. I don't have any, all speakers are members of the planning committee, have no relevant financial relationships, no commercial interests. The views and opinions expressed by participants and speakers attending ECHO sessions are solely their opinions and do not reflect the official positions or policy of UT Health San Antonio. And so some of our learning objectives for today will explain the historical development of peer recovery support services. We'll explore some of the key roles and functions of PRSS specialists. We'll recognize the impact of PRSS on addiction and mental health recovery. And we'll discuss some of the significances of peer support in contemporary healthcare. So the emergence of the recovery movement refers to a growing cultural shift in the emphasis on recovery from addiction, mental health, and other behavioral challenges as a journey of personal growth and transformation rather than a lifelong struggle with illness. The movement gained momentum recently, challenging traditional models of addiction and mental health treatment and advocating for a much more holistic approach to recovery. So some of those key elements would be the beginning of talking about person-centered care, where we recognize that people with addiction should play a central role in the decisions about both their treatment and their recovery. This approach contrasts with older models where people are often treated as passive recipients of their care. It also uses a strength-based approach, focusing on the individual's strength and resilience rather than their defects and weaknesses. It encourages people to build on their existing assets and skills to support their own recovery journey. Peer support as part of that is people who have successfully navigated their own recovery and serve as role models and provide support to those still on their journey. This helps to reduce the stigma that goes along with addiction recovery, and it provides a sense of community and understanding. The harm reduction approach acknowledges that abstinence may not be the only path to recovery for everyone. Harm reduction strategies can include safe injection sites, needle exchanges, and programs for individuals struggling with substance use disorders. The holistic approach is seen as encompassing various different life domains, including physical health, mental well-being, connections, and overall quality of life. And during this recovery movement, we've had to really redefine what success looked like. Success is not only complete abstinence, but can include significant improvements to one's life, such as regaining stable housing, employment, a sense of purpose in your life, and fulfillment. And cultural competence is also an important component to this, because culturally sensitive care strives to address the unique needs and experiences of individuals from different diverse backgrounds. And advocacy and policy change involves advocating for changes in policies related to addiction and mental health treatment. This can include promoting funding for evidence-based practices, challenging discriminatory laws, and fighting against the stigma associated with addiction and mental health. Next slide. Thank you. So we shifted from an acute care model to a recovery-oriented system of care. So in an acute care model, it was, how do we get this person into treatment? And in a recovery-oriented system of care, we look at how do we nest the process of recovery into this person's own environment, right? An acute care setting is often hierarchical, time-limited, and highly commercialized. And in a recovery-oriented system of care, there's much lower power differential, more time is sustained, an emphasis on continuity of contact. It's much more natural of an approach. And the provider, the peer recovery support specialist, is both a teacher and an ally. So the ROS model is what started the shift from an acute care model, like that you broke your arm and you got a cast on and you came back 6 weeks later and you were all better, to a long-term supports kind of a model. So, and it also promotes a much more compassionate and supportive model for care. So, next slide. So some of the values and recognition of peer recovery supports are contributed to several factors in understanding addiction and recovery. So one of the first things that helped this get off the ground was back in the 1980s, the recovery movement got started and gained some momentum. So rather than viewing addiction as a lifelong incurable disease, this movement emphasized that long-term recovery is possible and even probable. And it focused on the concept of recovery as a journey and not a destination, and the role of personal experience in achieving and sustaining recovery. And then lived experience was part of this recognition, as people who had successfully overcome addiction could begin to share their experience and serve as living proof that recovery is achievable, and that peers provide a unique perspective demonstrating that recovery is not only possible, but also sustainable. And then self-help and mutual aid groups, most of us have heard of them. They've been around for a very long time, typically like an AA or an NA, and they played a pivotal role in promoting the idea of peer support. Those groups were peer-led and relied on the shared experience of their members to provide support and guidance to one another. And then testimonials and personal stories from those in recovery became powerful tools for inspiring hope and change about the journeys of individuals who had successfully achieved and maintained recovery, had a huge impact on those people still struggling with addiction. So the reducing of stigma came as peer support efforts also helped to reduce that stigma that was associated with addiction through their stories individuals' recovery demonstrated that recovery was not a moral failing, but a complex health issue that could be addressed through support and treatment. And many people came out during the 80s and 90s and started saying, introducing themselves as people in long-term recovery and what that meant to them was, whatever that was. And that started to reduce the stigma in communities because people saw that their neighbors were in recovery and they never knew that before. So and then a cultural shift within the broader healthcare system to recognize the value of what's called patient-centered care and emphasizing of the importance of involving individuals in decisions for their own health. And then SAMHSA, Substance Abuse Mental Health Services Administration, played a huge role in promoting the recovery-oriented systems of care. They advocated for the inclusion of peer support in treatment and recovery planning, which led to policy changes and the beginning of funding for peer recovery support services. And then research and evidence-based practices as the field of addiction, recovery, and recovery services began to rely more on evidence-based practices. Research supported the effectiveness of peer support in promoting recovery. Numerous studies have demonstrated positive outcomes for individuals who receive peer support services. So as we see that happen, we start seeing peer support becoming integrated into healthcare systems, hospitals, addiction treatment centers, mental health facilities, community organizations, all began to realize the value of employing certified peer specialists to support their recovery. And you can, next slide. So as SAMHSA started promoting the recovery-oriented system of care, we started to see recovery being looked at more as long-term recovery, a person-centered approach that focused on both treatment and support. And SAMHSA is continuing to try to shift the focus from system management to a more holistic person-centered recovery. So SAMHSA developed the Recovery Support Strategic Initiative, which was launched to promote recovery-oriented services, build on recovery-oriented systems of care, and increase the availability of peer support services. The initiative was designed to support individuals in achieving and maintaining their recovery from addiction and mental health. Part of that was National Recovery Month. And in 1989, as a way for SAMHSA to promote the recovery-oriented services and reduce stigma. Today, National Recovery Month is an observance held every September to support and promote new evidence-based treatment and recovery practice, and the nation's strong and proud recovery community and the dedicated service providers and communities who make recovery in all its forms possible. So peer support and peer operated services, SAMHSA actively supported that integration of peer support specialists and peer operated services into behavioral health. This included funding and resources for training and certifying peer support specialists and the development of peer-operated organizations like recovery community organizations. Publications of the recovery-oriented resources began coming out, so people had training materials and could get information on how to move towards a much more recovery-friendly or recovery-oriented system of care. And then policy development and implementation. So they started to, SAMHSA was working with state and local governments and try to integrate recovery principles into healthcare systems. That I can say, 25 years later, we're still working on that bullet. And funding for recovery programs, various organizations and initiatives to promote recovery, provide recovery support services, and these grants and contracts continue to expand within SAMHSA. And research and evaluation, SAMHSA does support research efforts to evaluate the effectiveness of recovery-oriented services and programs, and the research findings help to shape the policy and inform best practices in the field. Next slide. So in last year, in September, the SAMHSA opened the Office of Recovery, and Paolo De Vecchio is the director, said 1 year ago during National Recovery Month, they officially lost the first office ever to advance recovery across the nation. In our first year, they hit the ground running, assembling a team of subject matter experts with lived experience, and addressed critical issues that we heard are important from recovery leaders and allies across the nation. And the last thing he said about that was, nothing about us without us. And you will hear that echoed across the country in many different meetings as we try to figure out what are our best approaches. So next slide. So certification of peer recovery support specialists. Not all states currently have a process for certification of peer support specialists. Some states do have a formal certification programs and regulations. And this year, SAMHSA put out a national model standard for peer support certification. So the national standards are out there. They're just guidelines, but as you might be able to tell by now, it's like we're driving down the highway at 70 miles an hour, trying to put the doors on the car. Things are changing and developing so quickly. So many states have tried to formalize peer recovery supports in their states and ensure that quality and effectiveness of services. So next slide. So research and evaluation, we have seen through the research and evaluation that we see increased engagement and retention of people in treatment. We see improved substance use outcomes, both abstinence and reduced use. We see people have a better quality of life. We have a reduction in hospitalizations and emergency department visits, improved mental health, improved crisis prevention and intervention, a reduction in stigma, cost savings, increase in empowerment and self-efficacy, community integration, reduction in criminal justice involvement, and positive peer relationships. I have a lot more I could say about that, but my 20 minutes is up, and they gave me an extra 5. So next slide. We got to get through it. Okay, so some of the roles and functions of PRSS. Obviously, peer support. A big function is advocacy, both big A advocacy, as this picture shows. This is from Washington, D.C. in September of 23, the Alliance for Addiction Payment Reform. All those advocates were at the Capitol for that. And then little A advocacy for the person that you're working with one-on-one, as well as recovery planning, empowerment, peer-led support groups, provide linkage to services, teach people about harm reduction, how to use safely, what you can do to keep yourself safe, continuous support over as many days, weeks, months, years as you like, cultural competence and community building. So you can do that. Individuals who provide PRSS have multifaceted roles, as you can see, in supporting individuals on their journey to recovery. Next slide. So here are some common settings for where you will find peer recovery support services delivered: recovery community centers or community organizations, substance abuse treatment centers, behavioral health agency, hospitals, emergency homeless shelters, transitional housing, correctional facilities, community-based organizations, primary care, integrated health, FQHCs, schools, colleges, veterans, LGBTQ+ centers, Native American reservations, faith-based organizations. It seems like nobody can get enough PRSS right now. Everybody wants to have some type of peer support within their organizations. Next slide. Okay, so some of the impacts: increased retention and treatment. We see that if you're hooked up with a peer support specialist while you're in treatment, you're more likely to stay engaged. You reduce your substance use, a decrease in reoccurrence rates if you're connected with people. The other thing that we often see is if you do have a reoccurrence, you're much more likely to re-engage in recovery. When you're connected with a community, you have an enhanced quality of life, decreased criminal justice involvement, empowerment, and self-efficacy goes up, and a huge reduction in stigma. Next slide. Okay, so some of the other significant pieces that happen with this is lived experience. People can see that when they are working with their peer, that they can also do that if they maintain their recovery. There's a huge reduction in stigma in the community when people see people in recovery engaged in community events and different things locally. They have personalized recovery plans, enhanced self-efficacy. Most relationships now are positive peer relationships. Peer recovery supports are cost-effective. They're recovery-oriented care where everything centers on recovery and what is needed for that person individually to stay in recovery. Advocacy, both big A and little a advocacy, is hugely important. Building a community of recovery where everybody in your community supports that. And then crisis prevention and intervention. And you can, one more slide. So research and evaluation findings, similar to, what we've already talked about, but absolutely you have increased engagement, retention of people to stay in treatment, improved outcomes, quality of life, hospitalizations and emergency department visits go down, improved mental health, reduction in stigma, cost savings, community integration, criminal justice, positive peer relationships. So you can see from all of this, the impact of peer recovery support services goes across the continuum, all with positive effects everywhere they enter the continuum. Next slide. Okay, so here's some of our references if you want to look those up. And I guess I'm going to say thank you. And I got 29 minutes, not too bad. And I want to thank you for your time. And now we're going to present a case.
Thank you so much, Cheryle, for this awesome introduction and laying the field for us as we move on in the series. I just want to open up the floor for any questions or comments from our learning community here. This is an awfully quiet group.
Cheryl, I'd be interested in your perspective on what's next. Looking back and seeing how we got here, do you have a sense of where we're going?
Well, you know what, Mark, I am asking these people to help us to say where we're going. I have my own personal views. Part of it is that I'm kind of afraid of where we're going, that we are being co-opted into doing things and losing the value again of peer recovery supports. That, emergency departments, instead of using a recovery community center or community behavioral health center to have coaches go in and work with them, are now hiring their own. That changes the model. Now you're working for a medical establishment as well as, criminal justice system doing that as they see the value of it. So that's a little bit of what I'm worried about for the future. And I think that recovery community organizations and people supporting these efforts across the nation need to be understanding of the impact of where they are sending money to, because sometimes it has a unintended consequence. So thanks for your question, Mark.
That's helpful. Thank you.
Thank you. Robert, I saw your hand.
Yeah, and thank you, Cheryl, for presenting. Really appreciate it. And this is more philosophical as you think about recovery support services, as you think across the spectrum, and not necessarily of where we're now embedding or integrating peers. And I also agree with your comment that peers should come from contracted RCOs because the infrastructure to supervise them and support them exists there, and implementation model efficacy is important. But more broad than that, across the spectrum of different types of RSS, you've got mental health peers, SUD peers, forensic peers, family peers. Peers are increasing for everything. And I wonder if you see or think that there is differences in how those peer services are delivered. And I think more specifically, like a direct question is in the way in our peers deliver in mental health recovery support services, SUD support services, and reentry support services. Do you think those are fundamentally different? Do you see them as the same? What's your take?
That's a great question. I think that they are fundamentally the same, but very different also, right? Like, I have no experience in the criminal justice system, none. So for me to be a peer trying to talk to someone who is going through a reentry process that I have no lived experience with, I don't see that I would be the most effective at that. But I could certainly talk to someone about my experience in 12-step based, abstinence-based peer recovery support, where I was blessed with a 7-day detox and a 28-day program and a year of outpatient for free, no cost. And and the other thing that I see that we talked about on a call earlier is like, I haven't experienced that by the grace of God in 34 years. So how impactful anymore is my message? Is it as impactful as someone with a year in recovery or 18 months in recovery that has just experienced what's going on, right? So I think there's some value, some real value in both people who are new in recovery being part of this process and telling us who have been a little bit out of the gate for a while, like, I know what I think is going on, what I hear, right? But using people who are actively using drugs also to be part of the process of what they need. They know what they need a lot more than us sitting around tables deciding what services we're going to give them, right? They can come to that table and say, I can get clothes. I need this, this, and this while we're gathering clothes. Thinking we're doing something. Does that make sense?
It does. Thank you.
Mm-hmm.
Thank you so much. And we will move on. Thank you again, Cheryl, for the wonderful presentation. We will move on to the next part of a session. Karen, if you could please share the announcements from the BVAL program. The Center for Substance Use Training and Telementoring provides high-quality education and best practices for responding to substance use. CSTAT can help enhance professional knowledge and self-efficacy to screen, treat, and make referrals for people with substance use disorders. To learn more, please visit us at cstat.ulisca.edu. Next slide. To claim your CME, you must text by midnight tonight. Text attend 1009-5084 to 844-502-1338. Karen will be sharing this information in the chat as well. Next slide. Do you have a research or evaluation work in progress that you would like to receive feedback on? CSTAT offers you the opportunity to present a research or evaluation related work in progress and receive feedback from a community of learning. There is no need to prepare a formal presentation. We will provide you a case form to fill out to assist with your case presentation. Do email us at cstat.utisca.edu. Next slide. The Texas Substance Use Symposium will be taking place on Feb 29 to March 1st, 2024 in Austin, Texas. Texas 2024 is now officially open to sponsors and exhibitors. If you're interested in learning more on how to become a sponsor or an exhibitor, please visit texas.org/sponsor Texas. Next slide. Just a reminder, our next session will be in January. The December recovery session ECHO session has been canceled due to the holidays. However, you can join us on our other ECHO sessions, which we will be having would be harm reduction, public safety, and TextRx. To learn more, please visit cstat.utisca.edu. And with that, we will move on to our case. Karen, if you could please share the case form, and Alyssa, you can take it away whenever you're ready.
Thank you. Hi, everybody. I'm Melissa Sage, and I am the Assistant Project Director for the facilitating organization at Harbor Care. I think this case study really fits in with Mark, your question, and the growth of peer recovery support services like Cheryl has presented pretty well. Just as a background, so the facilitating organization, I'll reference it as the FO. We were originally established in 2016, a program of Harbor Care, which is based in Nashua, New Hampshire. And we were tasked with building a robust and resilient network of recovery community organizations to increase access to peer recovery support services within the state of New Hampshire. So this was done through a state RFP process. That's how the FO was originally established. So we achieve this by providing funding, technical assistance, back office support, contract compliance to recovery community organizations all across the state of New Hampshire. So we started in 2016 subcontracting with 3 RCOs, and today we have 20 locations across the state. So a lot of growth over the past 7 years. And then, so just a background, we are now that we have all these RCOs established, we are kind of blessed that we have all this abundance of information and this infrastructure that exists across the state of New Hampshire. We now have 3 years worth of statistically significant data that has been evaluated by New Hampshire Department of Health and Human Services through the Bureau of Drug and Alcohol Services and their contracted TA provider, AFMC. They do the statistical analysis and create all these evaluations for us. And now we have 3 years worth of data that confirms everything that Cheryl said in her presentation, that peer recovery support services are effective. And we see this by measuring improvements of recovery capital. Our key indicators are, again, no surprise, right? Increased in community engagement, increased quality of life. engagement in peer recovery support services, group activities, stable housing, no shockers there. And we have 3 years worth of this data. So my case to you guys all really is, where do we go from here? We know what we've known, what we have now known for years, but how do we leverage the infrastructure that we've built and the information that we have to further develop and solidify the field of PRSS as a whole?
Thanks, Alyssa. I'm happy to kick us off. I haven't been part of some of these earlier evaluations, and certainly a happy and gracious partner that I use Recovery Link. Yeah, I think as we look at it, it's starting to get more granular in specificity. In not only does engagement in peer services impact these things, but for who and under what conditions, right? So really beginning to model, and probably through more sophisticated statistic modeling, where things like demographic controls or predictors in terms of race, gender identity, ethnicity, clustering or modifying how you're evaluating data across your different RCOs, that they're not likely implementing programs or offering the same exact services in the same exact way under controlled conditions, to begin to parse through of very much, I think, much more detail of how and to what extent and for who that they are actually working, right? Rather than this kind of grandiose and aggregate perspective that, well, our peer services are working in these settings, at least at this broader level, but just getting more specific. And I think that's where you're going to have to take your analysis, both to provide meaningful programmatic insights, right? Do we need to invest more time and resources in pregnant and postpartum services? Are BIPOC communities not even being served well? Or are they having variable outcomes to people that are unhoused or have lower income levels? At what threshold? Like these, you get to get more specific into the milieus or the recoveries that you're serving. And not that it's their outcomes are a fault of their own, but that the program themselves may be having gaps that haven't been identified. So more of like a quality assurance process, but I think also provides meaningful insight into the larger field, right? Because it gets us more specificity that we really don't have yet, because you have so many RCOs. And while it may be only generalizable to the 20 in New Hampshire or in models that are similar in the New England corridor, it's still very useful. And I'm sure there's a variety of other ways that y'all can have, but that's how I would be looking at it from a programmatic standpoint. That helps the broader field empirically, but more importantly for your RCOs, helps them provide services better.
Thank you so much, Robert. I have a question from Jordan.
Yes, hi, thanks. Thanks for the presentation. Where my brain immediately goes is the overall state of certifying peers, the training curriculums, because that I see on many levels, it's a bit of the wild, wild west. We have all these different models, all these different training entities. Not every state has a certification body. Some states, the certification body is a private entity. I'm a person in recovery who's not abstinent. I can't get certified in the state that I now reside in, right? Because they require abstinence. So not having just, and the word that I'm looking for is escaping my brain. It's been a long week. Consistency across the board of not only how we are training our peers, but how we're certifying them, what we are requiring of them. I mean, we still have states where most people with a criminal background can't get approved to get certified and work as a peer. So how do we achieve that consistency? How do we keep that in the hands of peers, right? And taking it out of private entities and taking it out of, certification bodies.
Thank you so much, Jordan. Sierra?
Thanks. And I lowered my hand very quickly there. Great points, Jordan. I think that the thing that I would add to that, maybe for this New Hampshire specific one, it might be a great place to start to kind of look internally, right? So what kind of certifications do we have among the people who are implementing these programs? It's a fantastic place to start. another layer of analysis there, like people with this level of training, this level of certification, what kind of outcome, are there any differences in the outcomes for our participants, right? But also just retention in the workforce, right? At least the RCOs that I've worked closely with here in Texas, we had a ton of turnover, especially when we had this just skyrocketing cost of living that we experienced in Austin. So a huge issue for a lot of RCOs, I know. So I could see that being a meaningful way to kind of add to that really important question you brought up, Jordan, but maybe narrow it to the specific focus of this this project. The other thing I wanted to bring up, another great direction to go in, huge lack in general in economic evaluations of all sorts of peer-driven or recovery-oriented services and interventions. So I do want to plug, not to toot my own horn too much here, but we did develop a cost-effectiveness calculator for long-term peer recovery support services. And so I know that the organizations that are involved in this evaluation effort, you should have that, all the information you need to use that calculator. It's definitely a good fit for this calculator component. There's another component that's for bystander naloxone distribution too, but that's a really important next step in all of this, right? We want to show that these programs work, right? But we also want to show to our funders that, hey, this is having a real economic impact, not just, to that local community, but, across the state. Maybe if you look even more broadly across the US, whether you're looking at just the medical system or you're looking at, kind of all this broad societal view is what we call it. There's also some interesting results kind of pulled out in that cost effectiveness calculator. It's not just cost effectiveness, which, can be a little bit of a vague concept sometimes. There's also things like averted medical costs, number of lives saved, things like that. And there's tutorials and resources to help you use that, and feel free to reach out. But it's also been highlighted in the literature that this is a huge area where we need help. And, it's you have a well-developed enough effectiveness evidence base that you are definitely ready to plug right into this and get kind of that's the next step in the evaluation hierarchy there.
Thank you so much, Sarah. Emily,
Are you going to put that in the chat, Sarah, for us?
Yep, I did, and I'll put it in there again just in case.
I must have missed it.
No problem.
Bye. Thank you so much. Emily, sorry to interrupt.
Oh, no, that's fine. I lowered my hand because I was thinking about a way to phrase this question without confusing everybody on the call. But so it kind of gets to Robert's earlier point about diversity of participants across a wide range of characteristics, and then diversity across the different settings themselves in which they're engaged, right? And that also speaks to Jordan's point about there being a lot of variability, a lot of differences in how peer recovery supports are operating. And so I just had kind of a clarifying question, because ideally what you would do if you were going to try to look at those different operational models, if you will, is not look at each one individually and do, this one-to-one comparison. But if there are kind of like broader ways of saying this is like kind of this type of operating model, right? And then we have, 10 RCOs that fall into this operating model. And then this is another type of operating model, kind of a thematic mapping of these different types of models. And I just didn't know, because I'm not as familiar with these supports, if that mapping has kind of been done already, or if that would be something you'd all have to kind of create to look specifically within these organizations. So very long kind of clarifying question, but yeah.
Yeah, so no formal mapping like that has been done. I can just say as like New Hampshire community in general, a majority of our RCOs would fall under like an RCO hybrid model where they're integrated in different settings and integrated harm reduction services with peer recovery support. That's what a majority of the New Hampshire RCOs are. And then a couple of them fall more in the traditional of centered in more peer recovery support services. And then we also have a couple of RCOs who are programs of family resource centers. So we have RCOs that are integrated at a family resource level as well. So there are definitely a lot of different organizational structures across the state where there would be, we would want to look at a closer level for outcomes like Robert suggested.
Thank you so much, Emily and Alyssa. Any other comments or questions? And thank you for that calculator. That looks really interesting. I was just looking at it right now.
The other thing, I think that New Hampshire is unique is in, the diversity of not our people, but our settings, right? So we can have a recovery center, like right under Mount Washington that gets hardly any visitors, but the 10 visitors a month, it's the only service they get, right? And then we have, recovery community centers in the capital or in some of our biggest cities that are almost embedded with drug courts and see, 60 or 70 people a week. And so how to take, the data that we have and like find ways to like compare like models, right? To see like if I have 3 recovery centers embedded with drug court and drug court participants, is that model working better than when we're embedded with family support? And embedded might not be the word, but close collaboration would probably be a better word, where we may identify a training and we'll train one person from the recovery center and one person from the family support center, and then we co-facilitate groups together to kind of integrate our services. So that might be an interesting way to try to parse out like who's what services and what areas in what components together make the best outcomes. But that's a lot of Excel spreadsheets in my mind. So I don't know.
Yeah, I mean, you're talking about, right, like the system within the system, right? A complicated kind of systems overlap. And so one thing that made me think of this, which Coreyville Saint actually I think is on this call and shared with me, is this recovery ecosystem index mapping tool, which I haven't used in my own research, but essentially it kind of thinks about the larger recovery ecosystem of different communities across the US. And so some of what you were talking about made me think of that tool and that mapping as a way to kind of quantify it and then include it in the models that you might run looking at outcomes across these different sites.
So is that the mapping tool from the Fletcher group put out? Because I just saw something like that.
I'm not actually sure. So it's your comment pinged that thought in my mind, but I'll have to find out.
So I did, if it is that tool, I did look at that tool and it wasn't that accurate in New Hampshire for some of the things. But I think what I read about the tool was they had just used public records to get the information. And so sometimes it's just not there, that there is a service or something there. But in bigger cities and stuff, it had a lot of information. Really, it was an amazing tool. It just, I would have needed to spend some time with them on New Hampshire, and I didn't have that at the time I clicked on the link. So, but I see what you're saying though, how something like that could be mapped into our data. What you're saying. Yeah. Okay. Thank you.
I think Robert put something in the chat too, because it looks like maybe he was a part of it. So I don't have the background knowledge. I just know of it from other folks. So
I mean, it is a good tool, and it's actually, it does publicly available data, which, you know, our outputs are only as good as our inputs. So it's an ongoing work in progress as more publicly and private inputs are made available specifically in there. It's large. For those of you in the space, it's based off the originating Ross model, our updated paper on recovery ready ecosystems modeling and recovery community capital, and then extending that even further with a lot of other publicly available geographic data sets that Rob Pack and ETSU's group, the Fletcher group, put out. But the tool is there. If you've never looked at it, your community is mapped. I will say for New Hampshire, most of you have very strong scores, even if they're not accurate. So
I
don't know what that
know.
is.
I did see that.
Yeah.
And then I thought it might be based on demographics, right? So if there's only 1,000 people and there is one treatment center in that area, we might get rated high. I don't know. I didn't know enough about it, but there were some interesting things in there. So
yeah, and it's it certainly has to do with demographics and prevalence and per capita availability. And again, it's an incomplete project, but I think if you've never used it before, if you're on the call, if you go to that link, find your county or region, click on it, and then click view details, you'll get a breakdown of everything that's going into it in terms of proxies or direct variables that are impacting that score. But it's a useful exercise, and it really was meant in large part to operationalize how we evaluate kind of ROSC frameworks as extended and kind of made more broad, including harm reduction services and programs, as well as traditional recovery supports and system supports. But yeah, there's still a lot of work to improve and make that more sensitive. I agree too, Cheryl.
Thank you so much. Yeah, go ahead, Cheryl. Go ahead.
Yeah. No, it's very interesting. And it is the same tool, you know, but I was one of our counties that has hardly any service had a 2 on a scale. So I was like, you know, but it's probably about the demographics, and they have a drug court there, and they have, you know, probably checked a couple of boxes, but so now I'm gonna look back at it again. So thank you.
Thank you. Corey, I see your hand raised.
Hi, yes. You know, that question about where to move forward now. So I feel like something that is emerging, that is people ask me about, is the idea of recovery vital signs for peers in the context of their job. Right? We think about outcomes for individuals who use our services, but there's a growing need and concern about peer well-being and how they're doing. And I feel like that would be something that could be useful to people in the future if it's done well, to better service the workforce of peers within the context of their job, and kind of resetting up some vital signs for them. And it should be, you know, and it should be useful. It should be useful information in terms of, you know, as well as getting barriers taken down that is keeping them out of the workforce. Things along that line, you know, a well-constructed kind of framework around that. So I'll just throw that out there as well. And, you know, thank you to the comments that my colleagues made too. It was really helpful. So.
Thank you so much. And we are close to time, so I will request Robert to give us a summary of the case today.
I would love to. And feel free, Hub members, if I miss anything or Alyssa to recap. So I think that one of the most bigger macro takeaways is we're starting to see some preliminary evaluations, and largely programmatic and from a health services research framework to come out. And we're going to start seeing this as how we increase internal evaluations and I think increase partnerships to continue to elevate them and move them forward with more specificity, more actionable insights, which is going to require meaningful partnerships across practitioners, peer providers, peer organizations, and recovery scientists, which is why we even have this echo. So that's a nice takeaway for me. I think second big takeaway is moving into the importance of cost benefit analysis or different types of financial modeling. To Sierra's point, I would encourage everybody to look at that tool and work that has been created similar to the Recovery Ecosystems Index that was mentioned. That there's tools now that can also be used to really speed up with you providing preliminary data, not having to crunch numbers in SPSS or R or lots of spreadsheets, like Cheryle would say, to provide some meaningful insights as well and to impact all of our work. And I think third is, at least for me, was a takeaway in the last conversation, a bit of it, to Cheryl's point, is that looking at tools that are available like the REI, our outputs are only as good as our inputs, and we still have a lot to do in increasing infrastructure and capacity to share information, like these evaluations coming out of the FO in New Hampshire, like different data sets that may not be funded by the feds, but that we have, to make sure that our outputs and the information we're using is much more meaningful and can actually impact our work. Hopefully many of you had other takeaways. Those three were mine, but exciting stuff, and congrats on all the good work in New Hampshire, Alyssa and Cheryle and the rest of the FO at Harbor Care, and looking forward to see where y'all take this and come up next. Hopefully you'll come back in about a year and told us how you made some changes and new insights you might have.
21 months, Robert. You got 21 months to change, make some changes. Maybe 20 now. So, but we'll be back.
Well, thank you so much. And thank you again, Alyssa, for presenting the case and initiating a discussion. And thank you all for joining today's ECHO. As a reminder, to earn CME credits, please complete a post-session survey using the link in the chat. If you'd like to present a case, please email BVAL Texas team. Remember, we don't have a session in December due to the holidays, and we will meet next in January on Wednesday, 17th of January. At noon. Have a wonderful rest of your day and have a wonderful Thanksgiving. Bye-bye.